Hello friends, today we are going to discuss the IC Bleed guidelines which are published in 2022. So first we will see the organization of the pre-hospital and the initial system of the care. In patient with the stroke, including spontaneous ICH, design and the implementation of the stroke public education program for diverse population focused on the early recognition and the need to seek emergency care rapidly is useful to reduce the time to diagnosis and treatment. In patients with the sudden onset of the neurological symptom or signs attributable to the potential spontaneous ICH, the use of stroke recognition in the severity tool is recommended for dispatch personnel and first responder to identify the potential stroke and facilitate the rapid transport to reduce the time to diagnosis and treatment. In patients with the stroke symptom attributable to the potential spontaneous ICH, immediate activation of the emergency response system is recommended. In patients with the potential spontaneous ICH, the early notification by emergency medical service staff to the receiving hospital is recommended to improve time to diagnosis and treatment. Now, in patient with the spontaneous ICH, regional system of the stroke care are recommended, so all potentially beneficial therapies can be made available when appropriate as rapidly as possible, including at minimum healthcare facility that provide initial spontaneous ICH care, including diagnosis and treatment, and healthcare facilities with the neurocritical care and the neurosurgical care. And all these statement has a class of recommendation 1. So in patient with a potential stroke, including spontaneous ICH, in geographical region where mobile stroke unit operate, such a mobile units are reasonable to enable the more rapid diagnosis and treatment than achievable by ambulance transfer. In patient with the potential spontaneous ICH, first responder training in stroke evaluation and care with the ability to provide airway and circulatory support whenever necessary is reasonable to detect and manage pre-hospital neurological deterioration. Now the next is diagnosis and assessment. Now regarding physical examination and lab assessment, in patient with a spontaneous ICH, focus history, physical examination, routine lab work and test on hospital admission should be performed to help identify the type of hemorrhage, activate medical services for activate medical services and for unfavorable outcome. Now, regarding his initial history, physical examination, and lab workup in patient with ICH, so the symptoms which are related to the ICH are headache, which is thunderclap. The patient will described as a thunderclap headache in case of aneurysm, then reversible cerebral vascular syndrome, and some instance of cortical venous sinus thrombosis. Then the headache will be of the slow onset in case of mass lesion, some cases of cortical venous sinus thrombosis, ischemic stroke with hemorrhagic transformation. Then the next symptom will be focal neurological deficit, seizure, and the decreased level of consciousness. Then there will be the history of vascular risk factor like ischemic stroke, prior ICH, hypertension, hyperlipidemia, diabetes, metabolic syndrome, and the imaging biomarkers. Then there will be the history of um, medication history is important because few drugs can contribute to the intracranial hemorrhage like anticoagulants, thrombolytic, antiplatelet agent, NSAID, then vasoconstricting agents which are associated with the reversible cerebral vascular syndrome like triptan, SSRI, decongestant, stimulants, then phentermine, then sympathomimetic drugs, antihypertensive and estrogen containing oral contraceptives. Then cognitive impairment and the dementia, which is associated with amyloid angiopathy and the history of substance use like smoking, alcohol use, like smoking, alcohol use, and the use of marijuana. Then on physical examination, we should properly assess airway, breathing, and circulation of the patient. Then a structural regarding structural examination, calculate NIHHS, which can be completed in minutes and provide the quantification that allows easy communication of the severity of the event to other caregivers. GCS is relevant to the patient with impaired level of consciousness. Then regarding lab investigation, we should send the complete blood count, blood urea nitrogen, creatinine, liver function test, glucose, uh, inflammatory markers like ESR and the CRP. Now, why it is relevant? Because anemia is associated with the poor outcome and hemorrhagic expansion. Thrombocytopenia is associated with the increased mortality. Acute kidney injury and hyperglycemia is associated with the worse outcome and mortality. Inflammatory markers are associated with the infective endocarditis. GFR influences the clearance of the direct oral anticoagulation. Then prothrombin time and activated partial thromboplastin time. These are the specific tests for the direct oral anticoagulation when appropriate. Anticoagulant related hemorrhages are associated with the increased hematoma volume, greater volume and the time interval of expansion and the increased morbidity and the mortality. Specific tests for the direct oral anticoagulation dilute thrombin time and anti-TNA activity may be useful for considering re-anticoagulation. Then cardiac specific troponin and ECG. Elevated troponin levels are associated with the increased mortality. Signs of left ventricular hypertrophy and other abnormalities on ECG can identify chronic hypertension, myocardial ischemia, and prior cardiac injury. Then urine toxicology screening like cocaine and the other sympathomimetic drug are associated with the ICH. So pregnancy test in women of the childbearing age. Uh, like uh, uh, there are certain conditions which are associated with the IC bleed like peripartum angiopathy, eclampsia, HELLP syndrome, and the sinus venous thrombosis. Then regarding recommendations of the neuroimaging for ICH diagnosis and active course, in patient presenting with the stroke-like symptom, rapid neuroimaging with the CT or MRI is recommended to confirm the diagnosis of spontaneous ICH. This statement has a class of recommendation 1 and the level of evidence B. In patient with the spontaneous ICH or intraventricular extension, serial head CT can be useful within the first 24 hours after symptom onset to evaluate for the hemorrhage expansion. This has class of recommendation 2A, level of evidence B. In patient with the spontaneous ICH and intraventricular hemorrhage with low GCS score or neurodeficit, serial head CT can be useful to evaluate for the hemorrhage expansion, development of hydrocephalus, brain swelling, and herniation. This statement also carries a class of recommendation 2A, level of evidence C. Now, recommendation for neuroimaging for ICH diagnosis and acute course. In patient with the spontaneous ICH, CT angio within the first few hours of the ICH onset may be reasonable to identify patient at risk of subsequent hemorrhage. This statement has class of recommendation 2B, level of evidence B. In patient with spontaneous ICH, using non-contrast computed tomography, markers of hemorrhage to identify patient at risk of hemorrhage may be reasonable. This statement also carries level of class of recommendation to B, level of evidence B. Then for in patient with the lobar spontaneous ICH and age less than 70 years and who has deep and posterior fossa spontaneous ICH and age less than 45 years, or if the ICH is a deep posterior for including deep or posterior fossa and age of the patient is between 40 and 70 years without history of hypertension, then acute CT angio plus consideration of venography is recommended to exclude microvascular causes or cerebral venous thrombosis. Now, in patient with spontaneous IVH and no detectable parenchymal hemorrhage, catheter intraarterial digital subtraction angiography is recommended to exclude a microvascular cause. Then in patient with the spontaneous ICH and CTA and magnetic resonance angiography suggestive of microvascular cause in the catheter intraarterial DSA should be performed as soon as possible to confirm and managing underlying AV malformation. All this statement has a class of recommendation 1, level of evidence B. Then in patient with lobar spontaneous ICH and age less than 70 years, deep or posterior fossa ICH, age less than 45 years, deep and posterior fossa and age 40 to 70 years, without history of hypertension, negative non-invasive imaging, that is CT angio and MR angio, catheter intraarterial DSA is reasonable to exclude microvascular cause. In patient with spontaneous ICH with negative CT and venography, it is reasonable to perform MRI or MRA to establish non-vascular cause of the ICH, such as deep perforating vasculopathy, cavernous malformation, or malignancy. Now, in patient with spontaneous ICH with who undergo CT or MRI at admission, CT angio plus consideration of the venography and MR angio plus consideration of venography performed acutely uh, can be useful to exclude macrovascular causes and cerebral venous thrombosis. In patient with the spontaneous ICH and negative catheter intraarterial DSA, no clear macrovascular diagnosis and other defined structural lesion may be reasonable to perform this intraarterial DSA, then may be reasonable to perform, then the intra-arterial DSA can be considered after 3 to 6 months after ICH onset to identify the previously obscured vascular lesion. Then regarding this medical and the neurointensive treatment for ICH. In patient with the spontaneous ICH requiring acute BP lowering, careful titration to ensure continuous, smooth and sustained control of blood pressure, avoiding peaks and the large variability in the systolic blood pressure can be beneficial for improving functional outcome. Now, in patient with the spontaneous ICH in whom acute BP lowering is considered, initiating treatment within the 2 hours of ICH onset and reaching target within the 1 hour can be beneficial and improve functional outcome. Now, in patient with the spontaneous ICH of mild to moderate severity, presenting with the systolic blood pressure between 150 and 220 mmHg, the acute lowering of the systolic blood pressure to the target of 140 mmHg with the goal of maintaining systolic blood pressure in the range of 130 to 150 is safe and may be reasonable for improving functional outcome. In patient with the spontaneous ICH presenting with the large and severe ICH, and those requiring surgical decompression, the safety and efficacy of intensive blood pressure lowering are not well established. Now, in patient with the spontaneous ICH of the mild to moderate severity, presenting with systolic blood pressure of more than 150 mmHg, acute lowering of the systolic blood pressure to less than 130 mmHg is potentially harmful. Now, regarding anticoagulation related hemorrhage, in patient with the anticoagulant associated spontaneous ICH, anticoagulation should be discontinued immediately and rapid reversal of anticoagulation should be performed as soon as possible after diagnosis of spontaneous ICH to improve survival. This statement has a class of recommendation 1, level of evidence C. In patient with the vitamin K associated spontaneous ICH and if the INR is more than 2, then the 4-factor prothrombin complex concentration is recommended in preference to this fresh frozen plasma to achieve rapid correction of INR and limit hemorrhage. And in patient with vitamin K associated spontaneous ICH, intravenous vitamin K should be administered directly after coagulation factor replacement, that is prothrombin complex concentrate or other, to prevent later increase in INR and subsequent hemorrhage. This statement also, this both of this statement has a class of recommendation 1, level of evidence B. Now, the next statement is patient with the vitamin K associated spontaneous ICH and INR of 1.3 to 1.9. It may be reasonable to use prothrombin complex concentrate to achieve rapid correction of INR and limit hemorrhage. This statement has a class of recommendation 2B, level of evidence C. Now, in patient with the direct factor 10A inhibitor associated spontaneous ICH, adnexanet alpha is reasonable to reverse anticoagulant effect of factor 10A inhibitor. In patient with the dabigatran associated spontaneous ICH, idarucizumab is reasonable to reverse anticoagulant effect of dabigatran. Both of these statement has a class of recommendation 2A, level of evidence B. Now, recommendation for anticoagulant related hemorrhage in patient with the direct factor 10A inhibitor associated spontaneous ICH, a factor 4 PCC and activated PCC may be considered to improve hemostasis. This statement has a class of recommendation 2B, level of evidence B. In patients with the dabigatran or factor 10A inhibitor associated spontaneous ICH, when direct oral anticoagulation agent was taken within the previous few hours, activated charcoal may be reasonable to prevent absorption of direct oral anticoagulation. The statement has class of recommendation 2B, level of evidence C. In patient with dabigatran associated spontaneous ICH, when idarucizumab is not available, uh, then prothrombin complex activated prothrombin complex concentrate or prothrombin complex concentrate may be considered to improve hemostasis. In patients with the dabigatran associated ICH, when idarucizumab is not available, then renal replacement therapy may be considered to reduce dabigatran concentration. All of these statement has a class of recommendation 2A and level of evidence B. So in patient with the unfractionated heparin-associated spontaneous ICH, intravenous protamine is reasonable to reverse anticoagulant effect of the heparin. In patient with the low molecular weight heparin-associated spontaneous ICH, intravenous protamine may be considered to partially reverse anticoagulation effect of the heparin. Now, both of these statement has a class of recommendation 2A and 2B respectively, and level of evidence C. Now, this is the schematic representation of the management of the ICH when the patient is on anticoagulation. So, the first step is discontinue anticoagulation therapy immediately, and the second action should be reversal of the anticoagulation as soon as possible. If we are using anticoagulation in the form of vitamin K antagonist, then the management is depending upon the INR. If the INR is between 1.3 to 1.9, then we can administer for 4-factor prothrombin complex concentrate in the dose of 10 to 20 unit per kg. And if INR is more than or equal to 2, then we can administer 4-factor prothrombin complex concentrate in the dose of 25 to 50 international unit per kg. If this oral anticoagulation in the form of dabigatran and factor 10A inhibitor, then we should ask the history when the last dose was taken. Then activated charcoal is used if direct oral anticoagulation is taken within the 2 hours. So if idarucizumab is available, then you use idarucizumab. If idarucizumab is not available, then prothrombin complex concentrate or activated prothrombin complex concentrate, or also we can go for the renal replacement therapy. So similarly, if we have used the factor 10A inhibitor, then reversal agent that we can use is adnexanet alpha. If it is available, use it, or if it is not available, then go for 4-factor prothrombin complex concentrate or activated prothrombin complex concentrate. Now, if the if we are using anticoagulation in the form of heparin, then use unfractionated heparin. If we have used unfractionated weight heparin, then use protamine, and in case of low molecular weight heparin also, we will go for the protamine. Then regarding antiplatelet related hemorrhage for patient with the spontaneous ICH being treated with aspirin and who require emergency neurosurgery, platelet transfusion might be considered to reduce the post-operative bleeding and mortality. Then for patient with the spontaneous ICH being treated with antiplatelet agent, the effectiveness of the desmopressin with or without platelet transfusion to reduce the expansion of hematoma is uncertain. For patient with the spontaneous ICH being treated with aspirin and not scheduled for emergency surgery, platelet transfusions are potentially harmful and should not be administered. Now, general hemostatic statement in patient with the spontaneous ICH with or without the spot sign, the effectiveness of recombinant factor 7A to improve functional outcome is unclear. In patient with the spontaneous ICH with or without spot sign, black hole sign, or blend sign, the effectiveness of the tranexamic acid to improve functional outcome is not well established. Now, the general inpatient care in patient with spontaneous ICH, provision of care in specialized inpatient unit with multidisciplinary team is recommended to improve outcome and to reduce mortality. In patient with the spontaneous ICH, the provision of care at center that can provide the full range of high acuity care and expertise is recommended to improve outcome. In patient with the spontaneous ICH and clinical hydrocephalus, transfer to center with neurosurgical capabilities for definitive hydrocephalus management, that is EVD placement and the monitoring, is recommended to reduce the mortality. In patient with the spontaneous ICH, care delivery that include multidisciplinary team trained in the neurosurgical assessment is recommended to improve the outcome. In hospitalized patients with the spontaneous ICH who require hospital transfer but do not have adequate airway protection, cannot support adequate gas exchange, or do not have the stable hemodynamic profile, then appropriate life-sustaining therapy should be initiated before transportation to prevent acute medical decompensation in transport. In patient with the spontaneous ICH without indication for ICU admission at presentation, initial provision of the care in stroke unit compared with general ward is reasonable to reduce mortality. In patient with the moderate to severe spontaneous ICH, IVH, hydrocephalus, or infratentorial location, provision of care in neurospecific ICU compared with the general ICU is reasonable to improve outcome and reduce the mortality. In patient with IVH and the infratentorial ICH location, transfer to center with the neurosurgical capability might be reasonable to improve outcome. In patient with the larger supratentorial ICH, transfer to center with the neurosurgical capability may be reasonable to improve outcomes. Now, regarding prevention and the management of the acute medical complication. In patients with the spontaneous ICH, the use of standardized protocol and order set is recommended to reduce the disability and the mortality. In patients with the spontaneous ICH, a formal dysphagia screening protocol should be implemented before initiation of oral intake to reduce the disability and the risk of pneumonia. Both of these statements has a class of recommendation 1, level of evidence B. In patient with the spontaneous ICH, continuous cardiac monitoring for the first 24 to 72 hours of admission is reasonable to monitor for cardiac arrhythmias and the new cardiac ischemia. In patient with the spontaneous ICH, diagnostic lab and the radiographic testing for infection on admission and throughout the hospital course is reasonable to improve outcome. Now, regarding thromboprophylaxis and the treatment of thrombosis, in a non-ambulatory patient with the spontaneous ICH, intermittent pneumatic compression starting on the day of diagnosis is recommended for venous thromboembolism prophylaxis. This statement has a class of recommendation 1, level of evidence B. In non-ambulatory patient with the spontaneous ICH, low-dose unfractionated weight heparin or low molecular weight heparin can be useful to reduce the risk of pulmonary embolism. In non-ambulatory patient with the spontaneous ICH, initiating low-dose unfractionated weight heparin or a low molecular weight heparin prophylaxis at 24 to 48 hours from ICH onset may be reasonable to optimize the benefit of preventing thrombosis relative to the risk of hemorrhage. In non-ambulatory patient with spontaneous ICH, gradual compression, stocking of the knee high or thigh high length alone are not beneficial for venous thromboembolism prophylaxis. For patients with acute spontaneous ICH and proximal DVT who are not yet candidate for the anticoagulation, temporary use of the retrievable filter is reasonable as a bridge until anticoagulation can be initiated. For patients with the acute spontaneous ICH and proximal DVT or PE, delaying treatment with the unfractionated weight heparin and low molecular weight heparin for 1 to 2 weeks after onset of ICH might be considered. Now, regarding nursing care, in patient with spontaneous ICH, frequent neurological assessment should be performed by AD nurse in the early hyperacute phase of care to assess change in status, neurological examination, or level of consciousness. In patient with spontaneous ICH, frequent neurological assessment in ICU and stroke unit are reasonable for up to 72 hours of admission to detect early neurological deficit. In patient with spontaneous ICH, specialized nurse stroke competencies can be effective in improving outcome and mortality. Now, regarding the glucose management, in patient with spontaneous ICH, monitoring serum glucose is recommended to reduce the risk of hyperglycemia and hypoglycemia. In patient with spontaneous ICH, treating hypoglycemia is recommended to reduce the mortality. That is, if sugar level is less than 40 to 60. Now, in patient with spontaneous ICH, treating moderate to severe hyperglycemia, that is, if sugar level is more than 180 to 200, is reasonable to improve outcome. Then regarding temperature management, in patient with spontaneous ICH, pharmacologically treating elevated temperature may be reasonable to improve functional outcome. In patient with the spontaneous ICH, the usefulness of therapeutic hypothermia to decrease peri-ICH edema is unclear. Now, regarding seizure and anti-seizure drug, in patient with spontaneous ICH, impaired consciousness, and confirmed electrographic seizure, anti-seizure drug should be administered to reduce the morbidity. This treatment has a class of recommendation 1, level of evidence C. In patient with the spontaneous ICH and the clinical seizure, anti-seizure drugs are recommended to improve functional outcome and prevent the brain injury from prolonged recurrent seizure. This statement also has a class of recommendation 1, level of evidence. In patient with spontaneous ICH and unexplained abnormal and fluctuating mental status or suspicion of seizure, continuous EEG for more than or equal to 24 hours is reasonable to diagnose electrographic seizure and epileptiform discharge. And in patients with spontaneous ICH without evidence of seizure, prophylactic anti-seizure medication is not beneficial to improve outcome and in terms of long-term seizure control or to improve the mortality. But this statement has a class of recommendation 3, level of evidence B. Now regarding neuroinvasive monitoring, ICP and edema treatment. In patient with spontaneous ICH or IVH and hydrocephalus that is contributing to the decreased level of consciousness, ventricular drainage should be performed to reduce the mortality. Now, in patient with the moderate to severe spontaneous ICH and IVH with reduced level of consciousness, ICP monitoring and treatment might be considered to reduce the mortality and improve outcome. In patients with spontaneous ICH, the efficacy of early prophylactic hyperosmolar therapy for improving outcome is not well established. And the bolus of hyperosmolar therapy may be considered for transient reducing ICP. So corticosteroid should not be administered for treatment of elevated ICP. Now, regarding surgical intervention, for patient with the supratentorial ICH of more than 20 to 30 ml volume with GCS score in the moderate range that is 5 to 15, minimal invasive hematoma evacuation with the endoscopic or the stereotactic aspiration with or without thrombolytic use can be useful to reduce the mortality compared with the medical management alone. Now, for patient with the supratentorial ICH of more than 20 to 30 ml volume with GCS score in the moderate range, that is 5 to 12, being considered for hematoma evacuation. It may be reasonable to select minimally invasive hematoma evacuation over conventional craniotomy to improve functional outcome. Now, same patient with the supratentorial ICH of more than 20 to 30 ml and GCS score in the moderate range, the effectiveness of minimal invasive hematoma evacuation with endoscopic and stereotactic aspiration with or without thrombolytic use to improve functional outcome is uncertain. Now, the for patient with the spontaneous ICH, large IVH, and impaired level of consciousness, EVD is recommended in preference to medical management alone to reduce the mortality. For patient with GCS score of more than 3, primary IVH and IVH extension from spontaneous supratentorial ICH of less than 30 ml volume requiring EVD, minimal invasive IVH evacuation with EVD plus thrombolytic agent is safe and is reasonable compared to EVD alone to reduce the mortality. For patient with GCS score of more than 3, primary IVH or IVH extension from spontaneous supratentorial ICH of less than 30 ml volume requiring EVD. The effectiveness of minimally invasive IVH evacuation with EVD plus thrombolytic use to improve functional outcome is uncertain. So recommendation for minimum invasive surgery evacuation of IVH for patient with spontaneous ICH and large IVH, impaired level of consciousness, the efficacy of EVD for improving functional outcome is not well established. For patient with spontaneous supratentorial ICH of less than 30 ml volume and IVH requiring EVD, the use of minimally invasive IVH evacuation with neuroendoscopy with EVD and without thrombolytic agent to improve functional outcome and reduce permanent shunt dependency is uncertain. Now, this is the schematic representation of intraventricular hemorrhage, the surgical management. If it is a spontaneous IVH is there and obstructive hydrocephalus is there, then we need to manage it with the EVD for mortality reduction and functional outcome benefit. If spontaneous ICH of less than 30 ml, if GCS score is more than 3, and if intraventricular hemorrhage requiring EVD, then we can use the EVD with thrombolytic agent for mortality reduction and functional benefit outcome. If our spontaneous ICH volume is less than 30 and this IVH is requiring EVD, then we can use this neuroendoscopy plus EVD plus thrombolytic agent to improve functional outcome benefit and reduce the permanent shunting. Now, regarding craniotomy for supratentorial hemorrhage, for most of the patient with spontaneous supratentorial ICH of moderate to greater severity, the usefulness of the craniotomy to improve functional outcome and mortality is uncertain. And in patient with the supratentorial ICH who are deteriorating, craniotomy for hematoma evacuation might be considered as a life-saving measure. Now, craniotomy for posterior fossa hemorrhage. For patients with the cerebellar ICH who are deteriorating neurologically and have brainstem compression and hydrocephalus from ventricular obstruction and or have cerebral ICH of more than or equal to 15 ml, then immediate surgical removal of hemorrhage with or without EVD is recommended in preference to medical management alone to reduce the mortality. Now, craniectomy for ICH in patients with the supratentorial ICH who are in coma and have large hematoma with the significant midline shift or have elevated ICP refractory to medical management, decompressive craniotomy with or without hematoma evacuation may be considered to reduce the mortality. In patients with the supratentorial ICH who are in coma and have large hematoma with significant midline shift and have elevated ICP refractory to medical management, the effectiveness of the decompressive craniotomy with or without hematoma evacuation to improve functional outcome is uncertain. Now, the outcome prediction in patient with the spontaneous ICH administered baseline measure of overall hemorrhage severity is recommended as a part of initial evaluation to provide an overall measure of clinical severity. In patient with spontaneous ICH, the baseline severity score may be reasonable to provide general framework of communication with the patient and their caregiver. And in patient with the spontaneous ICH, baseline severity score should not be used as the sole basis for forecasting individual prognosis. So anyways, this statement has class of recommendation 3, level of evidence B. So the conclusion statement that we can say is baseline severity score can be used for overall prognosis and to determine the clinical severity. Now, the decision to limit the life-sustaining treatment in patients with spontaneous ICH who do not have the pre-existing documented request for life-sustaining therapy limitation, aggressive care, including 2E, level of evidence B. In patient with the spontaneous ICH who are unable to fully participate in medical decision making and use of shared decision making model between surrogate and physician is reasonable to optimize alignment of care with patient wishes and surrogate satisfaction. Class of recommendation 2A, level of evidence C. In patient with spontaneous ICH who have DNR status, limiting other medical and surgical intervention unless explicitly specified is associated with increased patient mortality. So post-ICH recovery and rehabilitation. In patient with spontaneous ICH, multidisciplinary rehabilitation, including regular team meeting, discharge planning should be performed to improve functional outcome and reduce mortality. Class of recommendation 1, level of evidence A. In patient with spontaneous ICH with mild to moderate severity, early supported discharge is beneficial to increase the likelihood of patient living at home at 3 months. So this has a class of recommendation 1, level of evidence A. In patient with spontaneous ICH with moderate severity, early rehabilitation beginning 24 to 48 hours after onset may be considered to improve functional outcome and reduce the mortality. This has class of recommendation 2B, level of evidence B. In patient with spontaneous ICH without decompression, fluoxetine therapy is not effective to enhance post-stroke functional status. This has a class of recommendation 3, level of evidence A. In patient with spontaneous ICH, the very early and intense mobilization within first 24 hours is associated with the lower likelihood of lower likelihood of outcome. This has a class of recommendation 3, level of evidence B. Now, neurobehavioral complication. In patient with spontaneous ICH and moderate to severe depression, appropriate evidence-based treatment, including psychotherapy and pharmacotherapy, are useful to reduce symptom of depression. This has class of recommendation 1, level of evidence B. In patient with spontaneous ICH, the administration of depression and anxiety screening tool for in post-acute period is recommended to identify patient with post-op depression and anxiety. Class of recommendation 1, level of evidence B. In patient with spontaneous ICH, administration of cognitive tool in the post-acute period is to identify patient with cognitive impairment and dementia. This also has a class of recommendation 1, level of evidence B. Uh, in patient with spontaneous ICH and cognitive impairment, referral for the cognitive therapy is reasonable to improve cognitive outcome. Now, in patient with the spontaneous ICH, the pre-existing and new mood disorder requiring pharmacotherapy, continuation or initiation of SSRI after ICH can be beneficial for treatment of mood disorder. And both of these treatment has a class of recommendation 2A, level of evidence B. In patient with spontaneous ICH with the cognitive impairment, treatment with the cholinesterase inhibitor and the memantine might be considered to improve cognitive outcome. Again, this treatment carries a class of recommendation 2B, level of evidence C. Now, in patient with the spontaneous ICH, in whom risk of recurrent ICH may facilitate prognostication and management decision, it is reasonable to incorporate the following risk factor. For ICH recurrence into decision making, the lobar location of initial ICH, older age, presence number of lobar location of microbleed on MRI, presence of disseminated cortical superficial siderosis on MRI, poorly controlled hypertension, Asian in the black race, and the presence of the apoprotein E allele. These are the factors which are responsible for the recurrence of ICV, and this statement has a class of recommendation 2A, level of evidence B. Now, regarding BP management, in patient with the spontaneous ICH, BP control is recommended to prevent hemorrhage recurrence. This statement has class of recommendation 1, level of evidence B. In patient with spontaneous ICH, it is reasonable to lower blood pressure to systolic blood pressure of 130 and diastolic blood pressure of 80 for long-term management to prevent hemorrhage recurrence. This statement has class of recommendation 2A, level of evidence B. Now, management of antithrombotic agent in patient with spontaneous ICH and condition placing them at high risk of thromboembolic event. For example, a mechanical valve or a left ventricular assist device. Early resumption of the anticoagulation to prevent thromboembolic complication is reasonable. Now, this statement has a class of recommendation to a level of evidence C. In patient with spontaneous ICH with the indication for antiplatelet therapy, resumption of antiplatelet therapy may be reasonable for prevention of thromboembolic event based on the consideration of benefit and risk. This statement again carries the class of recommendation 2B and level of evidence B. In patients with non-valvular atrial fibrillation and spontaneous ICH, resumption of anticoagulation to prevent thromboembolic event and to reduce the mortality may be considered based on weighing benefit and risk. So in patient with atrial fibrillation and spontaneous ICH, in whom the decision is to make restart anticoagulation, initiation of anticoagulation within 7 to 8 weeks after ICH may be considered after weighing the specific patient characteristic to optimize the balance of risk and benefit. In patients with atrial fibrillation and spontaneous ICH deemed ineligible for anticoagulation, left atrial appendage closure may be considered to reduce the risk of thromboembolic events. Both of these statements has a class of recommendation to B, level of evidence C. Now, the management of other medication. In patient with spontaneous ICH, establish the indication for statin pharmacotherapy. The risk and benefit of statin therapy on ICH, outcome and recurrence related to overall prevention of cardiovascular event are uncertain. Class of recommendation 2B and level of evidence B. In patient with spontaneous ICH, regular and long-term NSAID is potentially harmful because of increased risk of ICH. This has a class of recommendation 3, level of evidence B. Now, regarding lifestyle modification, in patient with spontaneous ICH, lifestyle modification is reasonable to reduce the blood pressure. In patient with spontaneous ICH, avoiding heavy alcohol consumption is reasonable to reduce hypertension and risk of ICH recurrence. In patient with the spontaneous ICH, lifestyle modification, including supervised training and counseling, may be reasonable to improve functional outcome. All this statement has a class of recommendation 2A and level of evidence C. So in patient with spontaneous ICH, psychosocial education for caregiver can be beneficial to increase the patient activity level, participation and quality of life. In patient with spontaneous ICH, the practical support and training for caregiver are reasonable to improve patient's standing balance. Primary ICH prevention in patient with the high risk imaging finding. When considering primary prevention of ICH, it may be reasonable to incorporate any available MRI result demonstrating cerebral microbleed burden and cortical superficial cirrhosis to inform shared decision making about stroke prevention treatment plan. Class of recommendation to B, level of evidence C. Thank you.